Hello and thank you for joining in on today's training. Heart & Solutions is a proud provider of CE-eligible trainings for our counseling community. This training may be eligible for continuing education credit hours through either the National Board for Certified Counselors, provider number 7376, or the Association of Play Therapy, provider number 21-645. To obtain CE hours for today's training, be sure to follow the steps in the description below to find and take your quiz.
Thank you, everyone, and Katie for being here today. My name is Natalie Queen. I am a therapist here at Heart & Solutions. I'm really excited to be hosting this training with You Need a Training today. Before we begin, I'd like to take a minute to just review a few housekeeping items. As a quick reminder, everyone attending the training must be individually registered. So if you're joining with a friend and you haven't registered yet, you won't be able to access the CE certificate or get credit for attending today. For those that have attended a training with us before, you will see that we are on a new platform. So if you have any questions about how to access these things, please let us know. All the materials for today's training can be found in your course page by clicking on the paperclip in that top right corner. After the training ends, you will be able to access the quiz. You won't be able to access that until the training concludes today. So don't worry if you're unable to click on it now, but after you complete the quiz, your CE certificate will be automatically generated. This training is scheduled for 1 hour, so we don't have a scheduled break, but we're all human. So if you need to take care of yourself, go take care of yourself and take any breaks as you may need. With all of that, I'm going to introduce our presenter today. So today we have Katie. She is a licensed therapist, author, speaker, and group practice owner. She founded Creative Healing, a multi-location teen support center in the Philadelphia area, and wrote the #1 Amazon bestseller, You're on Fire, It's Fine. With lived experience as a teen who turned to self-harm, Katie is one of only 11 Linehan board certified DBT clinicians in Pennsylvania, the gold standard treatment for self-harm and suicidal behaviors. She equips parents and clinicians with practical trauma-informed tools to decode behavior as survival and create lasting change. And with that, Katie, I'm going to hand it over to you, and I'm excited for all the information you're going to bring for us today.
Thanks, Natalie. I appreciate it. I'm going to share some slides and get us started. I'm really curious, as I'm pulling things up, if show of hands are in the chat, how many of you work with self-harming neurodivergent teens, crisis-prone neurodivergent teens? I assume that's somewhat why you're here or want to learn more about that, but it's helpful just to know what the population is we're coming in with. Great. It seems like the majority of you here. So I'll be talking today about stopping the revolving door. This is strategies for neurodivergent teens in crisis, as I just paved the way for. As Natalie said, my name is Katie May. I share videos and tips every day on my Instagram at KatieKMay. So if you're someone who likes bite-sized information, feel free to follow along. But for today, you are in the right place if you work with teens who self-harm, who shut down, who cycle through crises. If you're someone who really wants to get to the root, to go beyond just symptom management and slapping a Band-Aid on things, and you want to use tools that integrate cognitive, somatic, relational strategies to treat the whole person in front of you, including the system that person exists in. And you want to understand behavior as communication and create change without forcing it. We don't want to force our clients towards goals they're not ready to achieve, but we also don't want to just host vent sessions and nice conversations. We want to find that sweet spot in the middle that helps our clients heal while also holding space for their needs, their autonomy, their pace for treatment. So what we'll cover today is, first of all, reframing behavior as a survival strategy. I talk about this again and again, that teens don't need us to just hold a space to build rapport. They need us to decode the message behind their behavior, to understand that it is something that is intolerable that is happening for them, leading to these behaviors that ultimately help them cope. I'll teach some tools for understanding what's fueling that emotional fire. We'll talk about how to identify emotional and somatic patterns, really understanding what drives self-harm, shutdowns, explosive behaviors. We're going to talk a lot about pattern finding and helping you help your clients understand what their behavior means. I think we cannot talk about treating teens without understanding how to integrate parents into therapy. And oftentimes I see the barrier with therapists is that they fear blaming or shaming or getting backlash from parents if they start to talk about how parents have their own things to work on, that parents have targets for emotion regulation and distress tolerance. So we'll talk about what it looks like today to conceptualize treatment with caregivers, to understand how they fit into the process so that we can treat the whole nervous system, not just the behavior, the whole system, not just the behavior. And in the end, break this cycle of hospitalization, break these unrelenting crises that happen with our clients so they can move towards that life worth living, which for my practice is always the goal, helping my clients move towards this successful, fulfilled, independent, whatever that looks like for them, life that's worth living, that they want to be in every day, that keeps them going and moving towards their goals, their joy, their fulfillment, whatever makes sense for them. So we'll talk about a lot of tools to achieve this. And you will leave with 5 neurodivergent affirming tools that help you decode behavior, integrate the body, and shift the systems that keep teens stuck. I always like to make sure that we're aware of the limitations of anything that's being taught. So these tools are designed to support clinical insight and therapeutic connection, but they are not to replace your own comprehensive risk assessment, care, or crisis intervention tools that are needed with the client that's in front of you. So I'll teach principles, I'll teach my protocols, but I never want that to usurp your clinical judgment or the needs of the client that's in the office with you. These tools are most effective when they are adapted to a client's developmental stage, their neurodivergence, their sensory profile. I see a lot, especially I train a lot of therapists, and when they're not feeling confident, they want to default to rules and protocols. And I find that to be challenging because while I teach principles and underlying functions and sometimes put them into tools or frameworks, we also need to understand that we work with humans and not with computer systems. So we need to adapt things to meet the person in front of us. Also helpful to acknowledge that access to supportive caregivers varies across systems, custody situations, cultural dynamics. And while I will talk a great deal in this training about caregiver inclusion, in some cases, this is not possible. In some cases, caregiver inclusion may be harmful if the client's lived experience or identity is invalidated, not affirmed, or pathologized. And I'll add to this, I'll use the words parent and caregiver interchangeably while also acknowledging that not everyone is a biological parent, and a caregiver and or parent could be a grandparent, could be a foster parent, could be another person in that teen's life. They're umbrella terms that I will use to describe the caregiver that supports the teen. As I've already said, no single tool works in isolation. This training offers a framework, not a formula. So please consider it like a buffet. Take what works for you, go back for seconds if you really like something, but it's certainly not a structured 3-course meal that has to be done in an exact order. As Natalie already shared, my name is Katie K. May. I'm licensed in the state of Pennsylvania. I own a multi-location group practice. I'm a 2-time author. I have a book for parents called You're on Fire, It's Fine. You can buy it anywhere you buy books online. It's for parenting teens with self-destructive behaviors. I also have a book coming out in July, Teen DBT in Practice. It's my framework for clinicians for how I work with high-risk teens, and I speak and train on these topics all over the world. I'm super psyched to be here talking to you about this. So my team has held over 120,000 sessions, and what we have learned is that there are certain behaviors that escalate teen concerns, and there are certain behaviors of caregivers and environments that de-escalate or validate teen behaviors and concerns. So on the escalation side of things, we first see misreading behaviors or misinterpreting behaviors or judging behaviors. So these are things like seeing or experiencing a teen's behaviors and labeling it something like attention seeking or manipulative or oppositional or defiant. And I can't see any of you or the chat, but I'd be curious how many of you have heard or used one of those terms in talking about the teens that you work with. And in addition to that, how open you are to shifting that narrative. And hopefully that's a lot because you're here today. We also see a lot of adults in these individuals' lives that want to fix it fast. And that includes us as therapists. So oftentimes it's the parents who want to jump in and say things like, use your coping skills, or it's not that big of a deal. And we'll talk more about those invalidating statements later in this training. But it's also professionals who feel this pressure to do a good job, to be the good therapist, to get to measurement-based outcomes, who want to fix it fast so that they feel like the good therapist. And I've fallen into this trap as well. But oftentimes when we do that, we're not just missing the problem, we become a part of the problem because we're jumping into fix before we fully understand. So we'll talk about that today as well, as how do we slow down the assessment process and truly understand the patterns. And then finally, we have our freak out adults, those that freak out at any small sign of suicidal ideation or self-harm or a safety risk. And while it's 100% valid to be anxious or concerned for a high risk or safety threatening behavior, we often have the difficult job, both as parents and professionals, of minding our face and our pace and our tone and how we respond so that we're not inadvertently conveying this message that we can't handle holding this information, which then leads to teens no longer feeling like they can share that information with us. And I've seen that on both sides. I've seen it on the side of teens saying, my mom can't handle this. She cries and crumbles when I express a safety concern. And I've seen it on the side of clients saying, my last therapist, as soon as I mentioned that I was the least bit suicidal, sent me to the hospital. So I feel like I can't be honest about this information. So really important that we manage our freak out so that we can be the safe space for the clients that we serve. On the other side, we see validation behaviors. These are things like fully assessing the problem before we jump in with a solution. I always like to say, if I can't understand fully why it makes sense for you to turn towards self-harm or substance use or suicidal ideation, then I don't understand the problem fully. I need to go back and understand more about what got you to this point, or what is so hard for you that these are the behaviors that you're engaging in. We want to be able to decode behaviors. This is understanding the function of a behavior, why it's happening, what's maintaining it, and then learn the tools and skills to respond with validation, while also at the same time helping our clients move towards change and healthier choices and behaviors. And that's a big task. Doesn't happen in one session, but it's holding all of those sides. So as we think about being more validating, decreasing escalation, we have to understand the revolving door problem, because if we keep treating behavior as something to stop instead of something to understand, we maintain or sustain this revolving door. So what happens is a behavior emerges. So a teenager is experiencing a great deal of distress. And with that distress comes a behavior that could be big, scary, or unsafe. And when that behavior gets to a point that the environment feels that it's no longer safe or cannot tolerate it, people begin to panic. Parents worry, again, validly, is my child safe? Can I keep them alive? Professionals start to worry too. What if this client acts on something? What if I make the wrong choice? What if this client is going to do irreparable harm on my watch? And what does that look like for me? And I support a lot of therapists who often catastrophize this as, I'll lose my livelihood, I'll lose my license, everything will go wrong, and my whole world will blow up. So it becomes this big, scary body thing for them. And so the choice for hospitalization is made to block the escalation of behavior, to put the client in a place where they can be monitored, removing access to means. And then everybody feels a little bit safer. Well, what I've learned is not all the time clients feel safer, but parents feel safer. Their shoulders come down from their ears. They feel like they can sleep a little bit more soundly because they're not waking up at every small sign in the middle of the night to check on their child in bed and make sure they're safe. And professionals get a little bit of a break from these clients with unrelenting depression and suicidal ideation. And they feel like they don't have to be on the hook to make these choices for a client to be safe or unsafe in the outpatient environment. So everyone feels a little bit safer until the client gets out of the hospital and they've been in a general population learning general skills. Then they come back home to the place where all of the triggers, stressors, and relationships that contributed to that hospitalization are happening. And then their emotions start to increase and the behaviors emerge again and people panic. And over and over and over again, we see clients go through this revolving door of hospitalization. I've seen it on the side of working in the hospital and I've seen it in the outpatient setting. It really made it one of my life's missions to stop this revolving door of hospitalization. And it starts with really understanding so clearly that the behavior is the solution and not the problem. Yes, it is problematic. Yes, it can be dangerous. Yes, it can be life-threatening, but we have to understand that for an individual who is struggling, that behavior is helping them in some way. So I call this my teen coping code. And what I want you to understand is that at the center is an individual with big and overwhelming emotions. So when someone is biologically sensitive, when someone experiences emotions in big, deep, and overwhelming ways, in my book, I call them fire feelers as a short way to describe, like, they're on fire with their emotions. They're all consuming. It's burning them up inside. It's big and painful and overwhelming. So when you can understand it that way, when you can understand that someone is all consumed and burning up inside with their emotions, it makes sense that they might think, I can't handle this, and engage in a behavior like self-harm or suicidal thoughts, actions, urges to make that fire go out quickly. So the big, overwhelming, all-consuming emotion tends to go out quickly or go down very rapidly when they engage in a self-destructive or impulsive behavior. And when someone's on fire with their emotions, it makes sense that they might turn to drug and alcohol use, dissociation, mindless scrolling, binging, anything to make that fire a little less hot. And when someone is on fire, they tend not to see shades of gray. It's either I'm on fire or I'm not on fire, right? And the same is true of someone whose emotions are very activated or they're at a high level of emotion, is that they tend to go to these extreme places, all or nothing, extreme thinking. I'm never going to get better. Nobody likes me. Everyone hates me. Everything is wrong and my life sucks. It's hard to find shades of gray when you're on fire. And if you're an individual who feels emotions in these big and overwhelming ways and you engage in self-destructive behaviors and you tend to think in extremes, you probably have relationship problems. Maybe you engage in conflict or cut others off, or maybe on the other side of that, you opt out of relationships before you get an opportunity to be rejected by others or feel abandoned by others. So others become unsafe and you feel unlovable. Relationships become challenging. And so when we look at this full picture, someone engaging in self-destructive behaviors, extreme thinking, relationship problems, it's pretty likely that you probably don't like yourself too much, have poor self-esteem, feel empty, unsure of who you are, feel pretty worthless. So when we zoom out and look at the big picture, someone who's engaging in these self-destructive behaviors, at the core, it's the solution for the problem of these big, overwhelming, all-consuming emotions. Because the truth is, if we focus only on stopping the behavior, if we look to our clients and say, stop self-harming, stop having suicidal thoughts, our whole goal is to decrease this. What we're doing is we're asking them to stop the very thing that's helping them. We're asking them to say, like, we're asking them to stop trying to put out the fire that's burning them up. So if that makes sense for you, that's understanding the function behind some of these self-destructive behaviors, which is the starting point. Now, what this looks like is biology and a misunderstood behavior become a crisis. What happens is we have this individual who their biology is innately sensitive. They feel like they're on fire and they're saying, I'm on fire. This is not okay. It's burning me up. I'm in pain. Please help. This hurts. And then they have an environment, which could be caregivers, coaches, siblings, grandparents, teachers, friends, anyone who's surrounding them and giving them feedback socially, saying, it's not a big deal. Just go take a walk. Maybe you're tired. Take a little nap. Everything's fine. And when that happens over and over and over again, the individual starts to lose trust in their internal emotion meter. They start to think, is it fine? Am I wrong? Am I not on fire right now? Is my emotion meter faulty? Should I not trust my own experience? And so they start to get this message that how they think and feel is wrong. What they're experiencing is wrong. And so then anytime emotions start to escalate and they get to that point where they're feeling that big fire, they think, nope, this is wrong, not this time. And they engage in the self-destructive behavior to make that fire go out. And that's how self-harm, chronic emotion dysregulation and chronic crises start to happen. So what I want you to take from this is that the behavior is the trailhead, not the target. We do look to the behavior and we do assess the behavior as the starting point for understanding what's behind that behavior. And so what we want to do is understand the story of emotion, which we know starts before the trigger, or we're going to talk about why it starts before the trigger. So I want you to understand that the buildup often comes before the breakdown. I have an almost 18-year-old who struggled, my own child, not a client, who struggled with school attendance, post-pandemic shutdown, returning to school, several years of not making it into school on a very regular basis. And counselors and well-intending adults were often saying things to me like, well, are they being bullied at school? Are they overwhelmed with academic demands? Is something happening at school that's bothering them? And I was very frustrated with these again, well-intentioned people, but this is a kid who's socially connected, academically gifted, does very well, but was struggling to make it to school. And ultimately what it came down to is that it wasn't any one thing that was happening at school. It was like the front end of that. It was going to school 6 hours a day, 5 days a week, having the sensory environment of the fluorescent lights, the crowded hallways, the lunchroom background noise that was happening when you're trying to connect with the person in front of you. It was the unrelenting sensory experience and the unrelenting demands that led to the breakdown. It was the buildup. It wasn't something that was happening on the back end. And so with that, I want to share this is a behavior chain, what we look at as a way to identify what's keeping a behavior in place, and what I want to highlight as important for a neurodivergent individual, and what we want to focus more on that we may not focus on as much with a neurotypical individual. So I want to start with a trigger or a prompting event. This is what sets off a chain of behavior. We'll use self-harm here because it's an easy, concrete example to use. But when we think about the trigger or a prompting event for self-harm, we also want to consider when this happened in the chain. So the mistake I see a lot of therapists make is that they look like way too far back. A client will say, well, I had a fight at school, and then I came home, I did my homework, I ate dinner, and then I self-harmed in my room at night. There's a lot of things that happen between that fight at school and after dinner in your bedroom. So likely that was a vulnerability, and we'll come back to vulnerabilities, but it wasn't necessarily the thing that set this chain of events off. So maybe if we're taking this example, it was after dinner, my mom said, did you do all your homework? But the look in her eyes was that she didn't believe me, and I felt a lot of shame. So that was the trigger, which led to judgments and emotions. Judgments like, she doesn't believe me, she thinks I'm untrustworthy, I'm never good enough for her, I'm always disappointing her, and feeling a lot of sadness, shame, guilt, maybe anxiety, maybe anger. And with that came an urge to self-harm that was too big to manage and led to the behavior of self-harm, which helped this client or this fake client decrease that emotion of shame. And then ultimately, after mom found out, get more warmth and positive reinforcement from mom, whereas previously this individual was feeling shame or disappointment toward mom. So that's the chain of events that happens. But what happens is that after an individual engages in a behavior and before, we come back to these vulnerabilities, these things that make someone more likely to experience big emotions, these things that make someone more likely to act on urges. And everybody has vulnerabilities. Some of the basic ones are self-care, like sleep, eating, getting enough activity, taking care of yourself when you're sick, taking your medication. But when and daily stressors. But when we think about a neurodivergent individual, we also have to consider the bottom-up processing that they experience of like taking in all of the sensory information in their environment that they may not necessarily be processing cognitively or thinking about consciously, but is impacting their overall capacity. So this particular client may have been at school, gotten in a fight, but also stressed about demands of school, also very overwhelmed with the noise, the lights, the crowdedness, having to pay attention in class, in the classes that are not interesting to them. So these are all things that reduce the capacity of someone and their ability to cope in a situation. So what I like to highlight when we're working with neurodivergent individuals is understanding what are those vulnerabilities that make every day more likely for them to act on something than someone who doesn't have those same vulnerabilities. So I use something called a sensory profile. I think it's like a screener that you can purchase where you can understand the different sensory experiences of clients that you work with and also understand what makes them feel more supported, what accommodations they may need. So for example, I'm someone who has low registration, so I can't see things when the colors are too similar. Like if it's a light font on a gray background, it's really hard for me to distinguish that. So I would need things that have more contrast in order for me to be able to see them without doing more work. So that would be an example of a sensory profile, sensory accommodation that would be helpful to know about your clients when you're supporting them. When we don't link the behavior to the underlying vulnerabilities, we miss the role of the environment and the nervous system in shaping how teens react and respond. We don't want to ignore this piece because it's invalidating for our clients and it's not neuroaffirming for our clients either. So when we look at what this looks like in an actual example with a neurodivergent client, vulnerabilities that they may have: sensory processing disorder, social anxiety, situational mutism, grieving a loss, overloaded with schoolwork. These are all just things that are running in the background, right? They're running in the background all the time, regardless of the triggers or stressors that are happening every day in this teenager's life. So a trigger could be getting out of the house for school. Every day they have to get out of the house for school. This is a really hard experience for them. They start to have judgments about themselves. There's something wrong with me. Why can't I do this? All my friends can do this. I feel a lot of shame and sadness around this, which leads to suicidal ideation. When they experience or express that suicidal ideation, they get to stay home from school. They get demands of schoolwork removed. Caregiver says, don't worry about your chores. I'll clean your room. I'll bring your food. And they get some relief from the pain of living because there is research that supports even thinking about suicide gives you some relief from the pain of your life experience. And so these are all things that the client will get from this experience of suicidal ideation. But again, we need to understand the full picture, including the everyday vulnerabilities. That buildup comes before the breakdown. And it's likely that all of these things make getting out of the house for school very hard for them because of these things that are happening. So you can understand the reaction without understanding the buildup. It's an important part of the full story of the emotion, and we don't want to skip that step. We want to take our time in really understanding it. Another piece that I think is really important when we're thinking about working with kids and teens is that the environment, to some extent, is the intervention. So looking to the caregivers, looking to the home environment, and understanding what their role is in the treatment process. I developed something called the river metaphor to help parents and caregivers understand what their role in therapy looks like. Because I think the misconception is that including caregivers in treatment means it's an information exchange. I'm doing a 15-minute phone call to tell them what's going on or to receive information, receiving emails of them telling me what's going on with the teen at home. And I think a lot of places operate this way where working with a caregiver is essentially they're an information provider or receiver. But that's not accurate to how we do treatment to truly support the environment being a mechanism of change. So this river metaphor looks like this. This is how I would explain it to a family as well. We are all on one side of the river facing the river. We're all looking at the other side of the river together. It is my job to help teen cross the river safely, effectively. And this means that I'm helping them develop tools, skills, goals, treatment interventions that become the stepping stones to get them across the river. It is teens' job to be open and willing to cross the river, even one baby step at a time. They have to be willing to try to cross the river. However, it is the caregiver's job to tolerate how the client crosses the river. Because what we know is that parents might say, hurry up, cross the river faster. I cannot tolerate you being in the middle of this river and me not knowing how you're doing. Or walk this way, right foot, left foot, micromanaging each step across those stepping stones. Or they might be an anxious parent and say things like, look out, the water's cold, there's an alligator over there, don't fall. Or they might be a critical parent and tell them that they're doing it wrong, that they actually need to walk this way across the river, or that stone isn't the right stone to step on. And so I'll typically tailor this metaphor to the family that I'm working with, but the idea is that we're helping caregivers to understand that how they interact with their teenager, how they talk about how their teenager is doing therapy is actually either helping or undermining the therapy process. And so it is important for parents to learn their own skills to tolerate distress, to learn their own skills to regulate their own emotions, to model it, but also to support their teen's emotion regulation, to learn the skills to validate rather than criticize, and to tolerate this slow rate of change that can happen when teenagers are in a high demand, low autonomy environment of going to school every day, having a lot of things placed on them that are not their choice, and they're doing the best that they can to get through, even if some of the behaviors or skills that they have are not the most helpful or healthy at this time. So the river metaphor helps us to define for caregivers what their role is in treatment, and it reinforces that they have a role in treatment, that it's not just about them dropping off their kid or reporting when things get better or worse. They also have to learn skills alongside their teen. And because of this, I developed a caregiver integrated conceptualization. So when we think about a fire feeler, when we think about someone who is highly sensitive, who is that biological sensitivity predisposition to feel their emotions in very big ways, they are also likely highly reactive, which means that they feel their emotions in very big ways and they react to those emotions quickly. Maybe they're lashing out, maybe they're shutting down, maybe they're engaging in a self-destructive behavior. So these are the biological vulnerabilities of the individual, the teen that we're working with. They also have a slow return to baseline. And this one I think is important because what this means is we have someone who feels their emotions in very big ways. And they're reactive to those emotions. They skyrocket up very quickly. And then it takes them a long time to get back to a baseline or a place of feeling centered. So they start to come down, they start to regulate a little bit more, but because they're so sensitive and so reactive, they get set off again before they get back to baseline. And so what happens is we have these individuals who are constantly triggered, constantly reacting, and never actually returning to their baseline. And they're in a constant nervous system state of activation, which again is a vulnerability, which makes it more likely for it to happen again and again. So when we have an individual like this, we have a parent who is doing the best that they can, but they may lack the capacity to respond in helpful ways, they start to unintentionally invalidate because over time, their capacity starts to dwindle to be validating, to be supportive, to stay regulated. They're tired, they're burnout. It's hard to stay in that space. And not to mention, they have their own stressors and their own triggers and relationships and things that are happening in their lives that make it hard to stay whole and respond in helpful ways all the time to their child. And so I share this to get the full picture that parents are doing the best that they can. They're trying to respond in the best ways. And you may see them when they're at the point of burnout and they no longer have the capacity to respond in skillful ways. And so understanding this and knowing that this is their place to work and these are their targets is important and helpful when we think about what we can do to support parents in this process. So we look at an example of this. We have a neurodivergent teenager who's easily startled. They're highly sensitive, easily startled. Loud noises cause them to cover their face, maybe cover their ears. They're very empathetic to the needs and emotions of others. And they're expressive, creative. They use their expressive outlets for their emotions. But they're also highly reactive. They engage in impulsive behaviors, yelling, lying without thinking about it. They often elope from school, leave situations, or engage in destructive behaviors like headbanging or cutting. And they need a lot of time in the absence of a stressor to return to their baseline, which is really hard when you're a teenager who has to be at school every day, who lives in a home, who has social demands, who has all the other things placed on them. They have a hard time letting go of things. They often cover themselves with a blanket to try and drown out all the sensory stimulation. And again, they leave situations. So they'll leave the home environment when things feel tense. They have a caregiver, we'll start down here, who unintentionally invalidates. They often oversimplify. Why can't you just go to school? Why can't you just do your homework? Your brother can do it. Why can't you do it? They personalize the teenager's emotions. They yell. They say things like yelling or venting is the client bullying me, or instead of their own emotions showing up. So they'll say like, she's bullying me every time that she gets upset, when really it's just the teenager who's getting upset and their emotions are really big, right? They're reactive. They misread the client's cues of walking away as disrespectful. So the client, the teenager, is trying to regulate themselves, but the parent is saying, don't walk away from me, this is disrespectful. So they're invalidating because they're misunderstanding. If we go back to those escalation behaviors, we're seeing a lot of them here. They're oversimplifying, they're minimizing, they're misreading the cues. And in addition to that, both parents have full-time jobs. They have a long history. This is a teenager, but they've been dealing with this since the teenager was a child, because it started as behavioral concerns in elementary school. They have fears about the future. I don't know if my child will ever make it to college. I don't know if they'll ever be able to live independently. Should I finish my basement so they can live at home? Because I don't know if they can do this. They have a lot of their own stressors, vulnerabilities that lead to more unintentional invalidation. And this is a cycle that's happening over and over again in the home. So client isn't getting the support that they need, parent isn't getting the support that they need. And these become the ways that we build a treatment plan to support this family. We want to stop blaming. We want to stop polarizing with parents, and we want to understand what they need to build buy-in with them, because they need support too. And when we can build them into the treatment plan and understand how to support them, it's going to make therapy work better for the teen as well. When we can put this together, when we can understand the triggers that happen for the teen that we're working with, their interpretation, their judgments and emotions, their behaviors and how it helps them, we can also help parents understand where they fit into this process. So when it comes to triggers, we can change the trigger. If every time a teen comes home, the parent says, how was your day? Is your homework done? And that triggers the teen, we could change that trigger. Parent can say nothing until 30 minutes after the teen comes home. Parents can change it from a question to a statement of, hey, I hope you had a good day. Parent can change the tone or the facial expression that they're using when they communicate. There are ways to change triggers that parents have control over. The interpretations and emotions that a teen experiences are what we work on with the teen. For us, it's in individual and skills group at our center. We can also work with parents to build validation skills. So we're not reinforcing harmful behaviors. We're in fact helping parents validate it makes sense why this happened, and teaching them behavior change strategies to not just provide warmth and attention after a self-destructive behavior, but in fact, in measured doses consistently. This is one of those places where I see, going back to like, what are the judgments that come up around these self-destructive behaviors when we say it's attention seeking or manipulative, which is what I hear often from caregivers when they're coming into therapy. What I see it as is they're missing the step. So teen engages in a behavior, parent gives them warmth, attention, and then they say they were just attention seeking. Well, there's a step in between that, which is understanding that you're feeding into that with your attention and warmth, but we don't want you to take that away. We don't want you to be not warm or give your child attention. We just want you to give it consistently and not just after a self-destructive behavior happens. So what I want you to take from this is that we can't support a teen's nervous system without changing how their support system responds. It is one of the most powerful mechanisms of change in teen treatment. I did this, I hope I get the numbers right. I think there's 168 hours in a week, and 1 to 3 of them are in therapy, depending on what kind of program that they're in. The rest of them are at home or school. So we really need to consider how the home and school environments can support the work that we're doing in therapy so that it generalizes and is reinforced in those environments, rather than therapy being the only place where skills can work. We also want to understand that fixing too fast is part of the problem. We talked about this at the beginning, the fix it fast folks who want to jump in to solve the problem, either because they're a parent who can't tolerate that things aren't working, or they're a therapist who wants to be a good therapist and make things work. And so I always go back to my own experience. When I was a new DBT therapist over a decade ago, I was experiencing a lot of distress around moving in with my husband. We were newlyweds. I chose him. I married him. He was my high school crush. I loved him. I was excited to be with him. But I found myself having these intense experiences of rage. I was so mad at him and it was so confusing to me and I didn't understand why. So I sought out a therapist to try and help me figure this out. And I found a DBT therapist because I believed in the treatment. It was what I was learning. I saw it working in my practice. And I was sharing this story with her. I was saying, I don't understand why I keep getting so angry. It's causing arguments for us. It's not working. Like, I want this to work. And about 5 minutes into this intake session, she looked at me and she said, the next time that happens, I want you to take 3 deep breaths and walk away. And she gave like a little smirk and a shoulder shimmy. Like she was like very proud of this practical advice that she was giving me to change my outcomes. I don't know how I made it through the end of that session, but I do know that I never went back and I felt incredibly invalidated because if I had the ability to take 3 deep breaths and walk away, I would not have been in that session with her. And so I felt that her jumping to this solution without full context for the experience and what was going on for me was quite invalidating and oversimplifying a solution, which later found out that it was neurodivergence, PMDD, all of these other things that would have been helpful to look at these patterns to understand for me so that I could actually find relief and understand how to shift things rather than jump in with a non-tailored solution that didn't quite apply to me. So I came up with this 3x3 tool to help people identify patterns quickly, identify the function behind behaviors quickly, and help folks understand what the intolerable emotion is beneath the behavior. One of the other things that I find really helpful and important about this tool is that we're not waiting for the next incident of a behavior to occur in order to assess it. When a new client comes into treatment with me, I'm always asking them, what is the first, worst, and most recent incident of this target behavior that we're working on? Depending on the client, it depends on what the behavior is. Maybe it's suicidal behaviors, maybe it's purging, maybe it's self-harm, it's something. But we're looking at the previous incidents of it to find patterns. And we're looking at, in 3-second increments, so very short timeline, what was happening before you acted on this behavior? What was the emotion or sensation that you felt? What was the thought or judgment going through your mind? And what was happening around you right before this behavior happened? We're also looking at during, when you are engaging in this behavior, what were you noticing in your body? What were your emotions? What was going through your mind? What was happening around you? What's interesting as we start to go through this is a lot of times clients will say at this during plays, well, I wasn't really thinking about anything, or no, I didn't notice those emotions when I was engaging in this behavior. So we start to see how even the behavior itself, while they're engaging in it, is very negatively reinforcing for them, removing the struggle for them during the behavior. And we also look at the same questions for what happens after. And we do this for multiple incidents so we can look for patterns. We can look for patterns throughout what's happening in each of these to come up with a shorthand way of understanding what this looks like for them. Because what we know is a solution without understanding may lead to another shutdown, may lead to more struggle, may lead to more invalidation, as you heard with my story as well. But once we come up with the pattern, it allows us to move into treatment more quickly in the future. I call this my recurrent pattern map. So if we go back and we see there are 3 incidents that we assess with our clients, and maybe in each of them we notice that what was happening before was some kind of experience of rejection. Maybe the first one was like, I had a fight with my boyfriend by text. Second one was my parents said that they were disappointed in me. And most recent one was they got an F on a paper that they worked really hard on. So we start to understand what patterns are. Trigger was some kind of rejection. They think I'm not good enough, nobody likes me. I feel a lot of loneliness and shame. And so I engage in my target behavior and it makes that loneliness and shame go down temporarily, which keeps this pattern in place. We look at an example of this. This is the escape the shame pattern. So when we come up with a recurrent pattern map, what we can do is then the next time a client comes in and they're sharing another example of this same pattern, we don't have to go back to assessment every single time. We can say, oh, is this your escape the shame pattern showing up again? And then jump into interventions and solutions rather than continuing to assess and assess and assess. So in this escape the shame pattern, we have the trigger being a reminder from parent. The teenager feels judged, they're disappointed in me, I'm bad. Their feelings are hurt. They feel sad. They feel some anxiety. They also feel some anger toward the parent. And so they lie, yell, and leave the house, which helps to remove the demand and distance them from the parent who triggered them, which makes the sadness, hurt feelings, anxiety, anger go down. So this is the escape the shame pattern. Once we identify that, then we can move into interventions with the client. When we have precision in patterns early on, it helps us to better understand prevention in the future. So we can also start to understand patterns of, if this is a trigger that shows up regularly, again, how can we change or remove that trigger? If we know that these are judgments that they experience, what can we do to help them decrease these judgments, or mindfully notice these judgments, defuse from them, help them not attach to them? How do we help them with mindfulness of emotion? How do we help them with distress tolerance to not act on urges? So we can start to build a plan to prevent these same emotion stories from happening in the future. And then finally, we think about the whole system needing a safety plan. I used to work in inpatient and partial care, and I must have completed 1,000 or more safety plans. I was the gatekeeper between someone being in the hospital and someone being able to leave the hospital, and it was my job to fill out a piece of paper. And I would meet with these patients, and I would say, what are your triggers? And they would say, my parents, school, friends. And I would say, what are your coping skills? And they would say, music, TV, naps. And they would have these rote answers that they would say with no emotion behind them, this generic treatment or this generic safety plan that we'd build again and again and again. And then I would see those same individuals show back up in the hospital 3 weeks later, because it wasn't a safety plan that actually translated to their real life, to their relationships, to the settings that they were in their real life. So I started to role play more with them. I started to recognize that safety plans needed to be rehearsed. They needed to be practiced. They needed to be applicable in different settings. So when a patient would say, music is my coping skill, I would say things like, okay, well, what happens when you're in the classroom and you can't put your headphones in and you can't leave the classroom? How do you cope? Like, what's your plan then? So we would start building these real world safety plans. And I want to bring you back to remind you of this revolving door, that a behavior emerges. We have a fire feeler who feels their emotions in these big and overwhelming ways. People in their lives start to panic. Hospital is used to block the behavior from escalating. Everyone in this client's life starts to feel safer. But what's important is that we don't just help this client cope with their overwhelming emotions and behaviors. We also want to help the support people in their life, help them cope, and help the support people cope as well. So I developed this teen and support system safety rating scale. There are a few things that I think are important about it. One is that safety is not a pass-fail. It is escalating levels of risk. And so this helps us understand, what are the escalating levels of risk? What are the escalating intensities of emotion? How do I feel that in my body, and how do I notice that in my thoughts? For neurodivergent individuals, sometimes it's a difficulty registering what an emotion feels like in your body. So I use something called the outside in strategy, where it's not necessarily how do I feel this in my body, but what do I notice my body doing? Maybe I'm more fidgety. Maybe I'm noticing that I need to pace more, or I'm looking around more. So body sensations don't have to be internal experiences. It's whatever cues the client off into recognizing they're in this state of mind or state of emotion. Big one here is, what do others see? When I'm at a place where my emotions are uncomfortable but manageable, others might see that I am closing in on myself. I'm no longer able to make eye contact. I'm asking to leave school early. So what we know is that anyone, when they're in a state of activation, they have a more difficult time activating their emotion, or articulating their emotions and asking for support. And this can be particularly true with a neurodivergent individual if they don't have access to being more verbal typically, and especially when they're in a state of emotional activation. So when we can proactively and at a state of calm start to identify what others might see when they're in those states, it can help to teach them what to do when the client is in that state. So again, I'll go back to using my own child as an experience here. I have learned that when they are in a state, when they're overwhelmed with the sensory stimulation of everyday life and having to go to school, and they'll often cover themselves with a blanket to remove all sensory stimulation, me asking any sort of questions in those moments is wildly unhelpful. But what does help is if I sit beside them and I bring them a drink and put it next to them and say, I'm here with you. There's a drink on the table. You don't have to do anything. So I have a cue. I know what to do. And my child also knows what to do independently to cope. So we want to build a support system to break this cycle of hospitalization. Each part in the system needs to know what to do at each level of escalation. Oftentimes I'll hear folks say, what is too acute for the outpatient? So I came up with an acronym to help me figure out, is it time to pack for the hospital or can this client stay home? I think about protective factors like the support system and what their environment looks like. I also think about acute risk factors like their access to means, but along with the access to means, I also think about, is this an environment that is validating and safe for them, or is this a wildly critical or invalidating home environment that will increase their risk at home? Can the family monitor? Can they remove access to means, but can they supervise? Are they able to be present if their teen says, hey, I want to hurt myself. Can you sit and watch The Office with me for 3 hours on the couch? Can they do that? Do they have young children to attend to? Do they work at night? We want to make sure the family can monitor. And also as a therapist, can you keep your emotions in check? Can you stay calm enough to make a wise mind decision so that you can make the right choice for the client in front of you that's not based on your own level of fear of liability or fear of what could happen? And I like to base this in 24-hour windows. We can always reassess. Sometimes delaying hospitalization is as effective as changing it altogether. And of course, we want to be able to speak directly to assess our clients. I always say, if you can't say the words, do you want to die? Then how is a client going to feel safe or comfortable saying to you that they do? When I assess intent, my very simple statement is usually like 0 to 10. If 10 is you definitely are going to die today or definitely going to kill yourself today, and 0 is you're not at all, where are you on the scale? We want to help free the environment of any kind of access to means. Yes, we want to educate families and caregivers on this, but I also like to empower my clients to do this themselves. Give Razor to parent when they get home. Be on Zoom with me and take whatever tool it is and throw it in the trash can outside. So empowering them to make that choice gives them some agency over it. And we're always establishing timelines, whether it's until the next session, whether it's until group in 2 days, until I see my psychiatrist tomorrow night. We're always giving a timeline for when that next step check-in is. I really want you to remember that real-world safety plans help teens use skills in the same environments that challenge them rather than removing them. So remember, when we can help our clients be effective in coping in the environments that trigger them, that's going to generalize better than teaching them skills in an environment that's removed. Of course, sometimes that has to be the choice, but I like to use least restrictive care whenever possible. Okay, today I promised you'd walk away with a new way to see behavior as a message, not a failure. Tools to map emotions and patterns with precision. That's the 3x3 tool. A new way to integrate parents without blame or backlash. That's the caregiver integrated conceptualization. Methods for accessing the emotion that drives the behavior, and a real world approach to safety planning, which is the Teen Support Person Safety Rating Scale that we just reviewed. With this information, I hope that you'll see the behavior as a messenger, trace the thread to the vulnerability, remembering to look for those vulnerabilities, shift the system, not just the teen, use the 3x3 tool so that you can find those patterns, and help your clients build real-world safety plans that work in the settings that they're in. If you want more support on stopping the revolving door, I would encourage you to download my teen risk decision-making checklist. You can get this for free at the top of the website at teendbtbook.com. I have a lot of free resources for therapists who work with high-risk teens. I'd love to support you if this info resonated and you want to learn more about it. That went so fast. It was like
I know, it's really good. I got so much valuable information though, and like that behavior chain, breaking it down is like, that is something that I think I'm going to be implementing today in a lot of my sessions. I mean, all of the resources you gave, I think really broke down how to address teen behavior and also just like how to interact with parents and help them feel involved in the process too.
Well, that was my goal, so thanks.
Yeah, Katie, thank you so much. This was great. It did go really, really fast. So, which is always a great sign. But yeah, thank you so much.
Before we wrap up, does anybody have any questions for Katie? I want to give a few minutes for that.
I think I just need to, I took a lot of notes, so I just need to sit down and kind of slowly process a little bit and think about specific cases, but it was super, super helpful. Things like your 3x3, are those available on your website?
Some resources are available. So towards
Okay.
the end, when I talk about the pack and the SAFE framework, those are available. My intake session document is available. Some of these things I teach in more depth in my my course, Treating High-Risk Teens. So
Okay.
that's kind of like teach the tools, and we also practice them, role play them, get feedback on them. So they're not all readily available for free, but they're all available somewhere if you're interested in diving into them.
Okay.
Cool. I know it was a lot of info, so if anyone has any questions, again, Instagram's the best place to reach me quickly. I'm chronically online as a neurodivergent person, so you'll find me there, but also feel free to reach out if anything comes up. I'm happy to clarify, and this was great. I'm grateful that y'all were here, and thanks for having me.
Of course. Yeah. Thank you so much once again for all of the valuable information that you provided. Just closing out for everybody, as a reminder, when the training concludes and you leave the call, you will be able to click on your CE quiz and post survey. I believe it's on the left-hand side. You will need to pass your quiz before you can access your certificate. While you need a passing score, you are able to retake the quiz if needed. If you need a copy of your certificate later, you are able to access that through your profile at any time as well. Just as those reminders, as Katie was saying, she has that website, the teendbtbook.com. We have Facebook, Instagram, and obviously her books, the book for parents, correct? You're on Fire, It's Fine. And then I'm excited to see the one coming out in July for Teen DBT in Practice. But other than that, thank you again so much, Katie. I really enjoyed this training. Thank you everyone for attending. And don't forget that you need a training.
Education credit hours through either the National Board for Certified Counselors, provider number 7376, or the Association of Play Therapy, provider number 21-645. To obtain CE hours for today's training, be sure to follow the steps in the description below.